Hello, everybody. Thank you so much for tuning in to my Compassionate Women's Health Community interview. This week, I've got Dr. Alice Whittaker, who's an gynaecologist obstetrician, joining us in our continuing our Adenomyosis Awareness Month in April. So my name's Belinda Chapman. I've got my Be Kinder to Yourself therapy practice here in Brisbane, and I run this Compassionate Women's Health Community. So let me just introduce Dr. Alice Whittaker for you, and then I'm going to hand it over to her to tell us a little bit more about her story. So Dr. Alice Whittaker is a caring and women-centered obstetrician and gynaecologist working in a mix of public and private practice in Brisbane. She has done her advanced training in minimally invasive surgery, persistent pain, and urogynecology. She offers a surgical treatment for endometriosis and fibroids, as well as tongue twisted sometimes. I was a laparoscopic hysterectomy and pelvic floor Botox. Alex has a warm and compassionate manner, as well as an open-minded and holistic approach, and prioritizes seeing the whole woman, not just her gynecological problem. That's what we love to hear. In her free time, she enjoys being in nature, yoga, and spending time with her French Aussie family. She practices at Vera Women's Wellness, which is out at Mount Sampson here in Brisbane, and rooms at the Mater in South Brisbane, and practices obstetrics through the Hatch Private Maternity Group. Welcome, Dr. Alice. Thank you for joining us.
Yeah, thank you so much, Belinda. Lovely to be with you here tonight.
Yeah, we are recording. We are pre-recording this at night time. Both had long days. Yep. Trying to stay sparky.
Yeah, this is not my office. This is, yeah. But, yeah.
We're in the middle of life.
In the middle of life, yes. So there may be some small children that barrel through that door, or a small child barrels through that door at any point in time.
We all understand, definitely. So Alice, can I hand over to you to tell us a little bit about, I love this sort of holistic approach that you have to your practice. Can you tell us a little bit more about what that means for you and for the ladies that you work with?
So I think doing our training in the public setting, where we're really limited by short appointment times and the constraints of what a public health system can provide. Anyone who's been in a public hospital clinic will know that the appointments, are very short, very punchy, and really that only have time to address that particular presenting complaint, to the point where sometimes we would talk, if someone wants to talk about a separate issue like their pap smears, when they're here for their bleeding, they have to book another whole appointment. Yeah. And I certainly found through my training that ended up really shortchanging women, because we're all interconnected, and not only must you address the woman's gynecological issues, but also look at her stress levels and her digestive health and her other health issues, because it's all interrelated. And so I'm so happy to be able to practice privately now and be able to say, look, I'm going to give you an hour and a half for an initial appointment if your issues are complex, so we can really drill down, figure out what's going on, and then provide you with that education so you understand what's going on, and talk about all the different treatment options, so it's less prescriptive in how we're treating women. So it's really lovely to be able to give women that time.
Yeah. And as you say, that education, because this focus, as I've said, is adenomyosis, and some of the stories I hear is that they're given this diagnosis and that's it. You've got adenomyosis. See you later.
Yeah.
So I can really appreciate that need for women to go, well, what does that mean? What do I do with this information now?
Absolutely. Yeah. And there are some women who quite happy with the various sort of mainstream treatment options that we provide, that most gynecologists provide, but even that takes time to explain. But then I guess you've got some women who perhaps have had some really negative experiences with hormones, and so a lot of, for something like adenomyosis, where hormonal manipulation is the mainstay of conservative treatment, that's not an option for them. So then wanting to explore some non-hormonal approaches, which have an emerging evidence base in some areas with some quite good evidence for some non-hormonal, non-pharmaceutical options. But that takes time to explain and to talk about the pitfalls and the, evidence where it exists and where it doesn't. So yeah, that takes time too.
Yeah, for sure, definitely. So can you tell me a little bit about your own story and how it led you into gynecology and obstetrics?
So my parents were, my dad and stepmom worked in women's health. So I was brought up with a real focus on women's health, empowering women, and being a feminist from my my late stepmom, and then followed in their footsteps and became a doctor, and probably didn't realize I really was passionate about obstetrics and gynae until my last year of med school, and doing surgery in the middle of the night and delivering a baby and realizing how incredibly exciting that can be to be a part of those times of a woman's life and to really be helping a woman when she really needs it. And then, just followed through and with my training. It's a really long training pathway, but I'm glad I stuck with it. I'm here at the end.
Yeah, I like women's bodies are like particularly complex, aren't they? Really, like the interconnection of the sex hormones, the brain, the body. Oh goodness, I can only imagine.
It's very complex, and obstetrician gynae is a bit of a unique specialty in that, particularly for both obstetrics and gynae, it's really a mix of surgical options, but also managing things medically and having a good understanding of hormones, endocrine system, pharmaceutical options, how different organ systems interplay with each other. So it's sort of a funny mix of surgery and medicine.
Yeah. So with the focus on adenomyosis, I'd love to just hone in on a couple of key questions around that. So from your experience and studies, how would you expect a woman to present if she's got adenomyosis, and what are some of those common symptoms that you see and might expect, and some of the not so common ones where you need to sort of go, I wonder if it's this, and do a bit more exploration?
Yeah, sure. Probably the most common is heavy, painful periods. And look, that's quite common. Adenomyosis is quite common. It's probably incidence of between 20 to 30% of women have adenomyosis at some point in their life. It's obviously more common older you get. So from 35 to 50 is sort of where most women are with the adenomyosis, but you do have exceptions to that rule, and sometimes you will have much younger women with adenomyosis that we're seeing. Typically, but yeah, heavy, painful periods are the most common symptom. But other things that could be suggestive of adenomyosis, painful sex, so specifically pain with deep penetration, because whatever's penetrating the vagina can hit the cervix, and the whole uterus can be really quite inflamed. It's an inflammatory condition, really. It's really inflamed, particularly just before a woman's period. That's quite a common feature. Back pain. So often people will say that with their period pain, they get an awful lot of back pain, and that seems to be more common with adenomyosis. Fertility can be an issue as well for those women who perhaps are the less common situation where a younger woman has it, or for women who are trying for a baby in their late 30s. And so it can affect fertility. And so that might be how it presents. Pelvic pain generally. We know that people have persistent pelvic pain, which is not just pain when you're bleeding, it's pain other days of the month, and sometimes that's how it presents.
So how does it affect fertility?
Well, in the same way that endometriosis can affect fertility. So the idea with adenomyosis is you most people listening to this will probably be aware of what it is, but just to explain that. So it's endometrial-like cells. So the cells that normally line the uterus are endometrial cells that respond to hormones and will shed when we have that drop of hormones, and that's what a period is. So cells similar to that, endometrial-like cells, deposit within the muscle layer of the uterus. And those cells, like the endometrium, are responsive to hormonal fluctuations. So when we get that drop of estrogen and progesterone that triggers menstruation, we get, yes, a little bit of the simplistic version is shedding and bleeding into those little deposits within the muscle layer, which, as you can imagine, is pretty painful because the blood doesn't have anywhere to go. But really the key part of it is inflammation. And so all of those inflammatory markers sort of exist there. From a fertility point of view, can mean inflammation is quite counteractive to an embryo implanting. So, Mama. Mama. So, one more moment.
Yeah, no, you're right. We're back.
Oh, sorry about that, everybody. It's life. So yeah, so I guess inflammation is quite makes for a hostile environment for an embryo to implant in. And I mean, sometimes we'll see women with adenomyosis who just have such intractable bleeding, and their bleeding loses a cyclical pattern to it. They don't know when is it period, when is it not. Quite often they're bleeding so much that they're on progesterone-like hormones that trying to rein in the amount of blood loss and pain. And so that's, you can't, it's very hard to fall pregnant when you're on all those hormonal agents as well. So it can be a very sad story for those younger women in their 30s who are trying to fall pregnant and have really bad adenomyosis.
Yeah. Well, I remember when I was diagnosed, what triggered my gynae to investigate was most of the year I had a lot of spotting and bleeding. It wasn't necessarily heavy or painful bleeding, thankfully, but it was the persistence of it. So it was, I was lucky to have 8 to 10 days out of a 24 or 26 day cycle where I wasn't spotting or bleeding. And I was getting pretty frustrated with it. And so I went to my gynaecologist, who was also a fertility specialist, and said, look, I'm pretty ready to end my cycle, but I know I won't forgive myself if we don't do one last round of IVF. And that triggered then the MRI to diagnose it. And I was on Zoladex for the 3 months to just shut everything down, and then the final IVF cycle. So yeah, it was like, I count myself quite lucky that was enough for her to suggest adenomyosis.
Yeah, because not everyone would have done an MRI for that. And so it's probably underdiagnosed. We used to sort of say to people, the only way to diagnose it is by doing a hysterectomy and looking at your uterus under a microscope. Whereas I think we now have enough quality imaging and expertise in imaging, so ultrasound and MRI, that you can sometimes you can make a diagnosis on that. Yeah.
Do you need?
Yeah, sorry.
Okay, so we were just
take 3.
We were talking about diagnosing and the imaging to be able to do that.
Yeah, that's right. So I always encourage my patients to go to a women's imaging centre. I can't emphasize that enough for whatever gynecological problem. A general radiology centre does a little bit of gynecological scanning, but a women's imaging does nothing but that, and the sonographers know what to look for. And for looking for things like endometriosis, we need it's in real time, so we see what organs move against each other. For adenomyosis, really getting good 3D views of the uterus, and be able to characterize what's going on, and getting a radiologist who knows what to look for in their reports.
Yes.
So yeah, can't emphasize that enough. So you get the diagnosis if it's there.
So when you were talking about those common symptoms of adenomyosis, I was hearing, well, that's very similar to endometriosis, really, isn't it? So does it come down to those diagnostic tools? That's what's going to help you differentiate between adenomyosis and endometriosis?
Yeah, I mean, I always call them sister conditions, because endometriosis is essentially the same process, but those endometrial-like cells are growing outside the uterus on the peritoneal or pelvic lining or on the ovary. But in the same way, it responds to hormonal shifts, and you get shedding and bleeding and inflammation during the hormonal shift. So that's what endometriosis is, same process, just different place. But endometriosis is probably more difficult to diagnose on ultrasound than adenomyosis, in fact. And often it will only really show up if we've got scarring or really deep nodule, or pelvic organs stuck to each other, or a big endometrioma. I guess ultimately the diagnostic tool that's the gold standard for endometriosis is laparoscopy. And that, when doing laparoscopy, you've got a camera in someone's belly button and having a little look around their pelvic organs. And so you can see what's outside the uterus in the pelvic cavity, which is endometriosis if it's there. Adenomyosis, remember, it's inside the muscle. So even if you do a laparoscopy, you won't necessarily know if someone's got adenomyosis or not. We talk about, sometimes at laparoscopy, we see what's called a globular uterus, which is one of the hallmarks of adenomyosis, where the uterus just looks, it's bigger than you'd expect for a woman who's maybe never had babies or of her age. She's just got a bigger, sort of bulkier, blobbier uterus. So sometimes we'll get an idea of that from laparoscopy, but we can't really diagnose adenomyosis from laparoscopy.
And so I remember when my gynecologist, fertility specialist, was talking to me about it, she was talking about how it might affect carrying a pregnancy. Is that a concern?
It's probably more about the fertility and the falling pregnant, but that is probably a small link there with miscarriage, but it's much more about falling pregnant. And that information that
you were talking about, definitely. And in terms of treatment and management of adenomyosis, what are some of the options that you discuss with your patients?
So probably because it's a hormonally mediated condition, the most standard approaches are to use hormones to turn off someone's menstrual cycle, because if you're not having a hormonal shift and not having periods, you're also not going to have the monthly activation of your adenomyosis or endometriosis, in fact. So the contraceptive pill is often the first line, because it's more familiar to people, and you can be started easily by a GP. It's not always the most appropriate thing for women as they get into their late 30s and 40s for other health reasons. They might have other comorbidities that mean taking the pill is not a great idea for them. And some people just don't like being on the pill, because those synthetic progesterone-like hormones don't agree with everybody. They're very good at shutting off periods and very good at stopping us falling pregnant if that's what we want, but they can be problematic for some women's mood, as well as some other hormonal side effects. Yes, it's very common. So often women have worked their way through a number of different pills, and sometimes they'll find they'll hit a jackpot and they'll find one that really agrees with them. But when people are coming to see me as a gynecologist, usually we've probably exhausted that line, and we're thinking about another hormonal option. Probably the Mirena IUD is my preferred option for adenomyosis. And that really tiny amount of progesterone-like hormone that the Mirena releases does dampen down those little adenomyotic deposits really nicely. And most people will be ovulating with the Mirena after about 12 months. So you usually can get those lovely natural hormones that we're getting from our own ovulation. So I'm a big fan of the Mirena. The Kyleena for women who are really scared of hormones, because the Kyleena offers them a lower dose of the progesterone-like hormone. So that's probably the most common intervention that we'll talk about. Occasionally there'll be a woman who has adenomyosis who we may talk about an endometrial ablation. I have to say it's not my favourite option. Endometrial ablation is where the lining of the womb is burnt off in a surgical procedure under general anaesthetic. It's really good for stopping period flow. It's not so good for stopping the pain that often comes with adenomyosis, or the painful sex that comes with adenomyosis.
Yeah, okay.
Because we can't burn off the adenomyosis deposits that are deep in the muscle. We're just burning off the uterus lining that causes the bleeding.
Yeah.
Tend not to do a lot of that for adenomyosis patients myself. It's not to say there's not exceptions where it's appropriate.
Yeah.
And I think for painless heavy periods, it can be a great solution.
Okay. Yeah.
And hysterectomy is the kind of last port of call that's available, and obviously it offers a really definitive solution for adenomyosis. If you don't have a uterus, you're not going to have any more adenomyosis. Obviously, it gives you a 100% guarantee of no more vaginal bleeding, and usually hysterectomies these days can be done with keyhole surgery, so that minimally invasive approach. Yeah.
And then where is that line that you would draw as to whether you need to take the ovaries as well in that situation?
Yeah. We would be very, very, very reluctant to remove someone's ovaries prior to menopausal age, which is around 50. So we know that women really depend on that lovely estrogen hormone that our ovaries make for bone health and cardiovascular health, stopping hormone hot flushes and other menopausal symptoms, for mental health, for good sexual function and sex libido. So estrogen is magical stuff for most women. However, if a woman is got very grave concerns about history of ovarian cancer in her family, then that's a separate discussion that we'd open up.
Yeah.
That would be the very, very rare exception. We'd really be aiming to keep her ovaries in place.
Yes. Yeah. And so what are some of the success stories that you've seen with some of your patients in this?
So I guess lots of success stories, countless Mirenas and Kyleenas, and that's usually something we can do in the rooms. It takes 20-30 minutes, and it can totally turn around someone's pain and bleeding. Under no illusions, I know that's not everyone's solution. There'll be people listening to this who have not had that that solution, and I'm sorry if that's you, because it would have been nice if it could have been that simple, but that does work for a lot of women. For women who have chosen to go for hysterectomy or have had to go to hysterectomy because other things have failed, usually that also offers a really great turnaround, and just instantly they don't have those horrible, heavy, painful periods. And that can be really transformative for a woman to be able to reclaim her life and make her adenomyosis a thing of the past. But I've also got some stories of women who either are wanting to maintain their fertility or particularly wanting to avoid synthetic hormones, who we've used some non-hormonal options. So a woman comes to mind. She was in her mid-20s and had very bad adenomyosis and pain and bleeding, and used high-dose curcumin. So curcumin is actually the active ingredient in turmeric.
Yeah.
And there's increasingly larger volumes of evidence in the mainstream literature, medical literature, about curcumin for all sorts of inflammatory conditions, so arthritis and even cancer, but it's really got a lot of bandwidth in the adenomyosis space, so it can be really great at helping reduce and calm that inflammation that's the adenomyosis is triggering. And that paired with fish oil. So again, there's some good evidence for fish oil with heavy painful periods. N-acetylcysteine, and so sort of that sort of cocktail. Some magnesium can be great for periods, and zinc. Again, under no illusions, that will be a lot of women it doesn't work for, but this particular woman had had an absolute turnaround with that approach, and
Amazing.
was essentially symptom-free from a period point of view.
That's incredible. Did you have to, because I know with my particular experience, the Zoladex, 3 months of the Zoladex and going into that artificial menopause to kind of shut it down enough, and I haven't had the symptoms by I mean, I hadn't really been symptomatic with my endometriosis anyway, but that was the end of 2015, so that's 7 years ago, and I haven't been really symptomatic with it. So I wonder if it was just that hard hit of that, that 3 months, and then my lifestyle was able to sort of maintain that.
Look, Zoladex, I have to be honest, I don't use Zoladex very much for endometriosis or adenomyosis. I see it as a stopgap measure for things like fertility, or for holding things at bay while we wait for surgery. Just because Zoladex can have some pretty gnarly side effects. It induces menopause. So you might have remembered like getting hot flushes and dry vulva, mood change and all those things, and you need that estrogen. So eventually we have to start adding back estrogen with patches.
That's right.
If it's longer than about 6 months. So look, for some women that will be what their gynecologist or specialist has had to do to help there with adenomyosis. But I guess I use it sort of as a stopgap measure. That's
right. And it's such an individual situation to diagnose and reflect on, person to person really as well, isn't it?
And everyone's got their own experience, and everybody's body is different and responds differently to different things, and we haven't even got into all sort of dietary health, like gut health and stress and endocrine disrupting chemicals and all the other factors that we know can be relevant for both endo and adenome.
Definitely. So my final sort of question I ask for my practitioners, and it kind of leads on from what you're saying, is what are some key tips that you think are fundamental to good women's health that you love sharing with your patients and audiences?
Okay, so I guess it's very, very broad, but I guess remember that we're all interconnected, and the health of our gynecological system may be a reflection of what else is going on in the rest of our body. So particularly probably the easiest, the low-hanging fruit in terms of what we can do to help our overall health is I always start with diet. And I think diet is such a powerful tool to help really improve a woman's health. So for example, with adenomyosis, often we know that one of the risk factors is estrogen and high estrogen states, and we know women who are overweight are more likely to suffer from adenomyosis because of their high estrogen states. So using use many vegetables, and particularly brassicas like broccoli, cabbage, kale, those sort of vegetables in our diet to help our bodies metabolize that estrogen and help our gut health process estrogen, because our gut is incredible when it comes to being able to do that. It's got a whole bacterial community called the estrobolome that metabolizes estrogen for us. So really paying attention to our gut health. And we talk a lot about a Mediterranean style diet, which is intrinsically anti-inflammatory, and we know that from research in all areas of medicine can calm inflammation. So lots of plants and legumes and fish and chicken, but limiting red meat, and really avoiding processed foods and trans fats in processed foods, and avoiding a lot of sugar and a lot of alcohol. So diet is incredible, and there's great resources, nutritionists and dietitians that are around to help you. And I will so often refer to my sort of handpicked selection of dietitians that I work with, or nutritionists. So that's probably my first thing is, improve all of our health, and particularly our diet. The second thing I think is, again, because we're all connected, is stress. And remember, our reproductive system is powered by our pituitary gland, which is powered by our brain. And if our brain is full of stress, things just don't work as well. And running alongside our hypothalamic pituitary ovarian axis of hormones is our hypothalamic pituitary adrenal axis of hormones. So that's the stress hormones, and these things do interplay. And so when people have really stressful, busy lives, stressful jobs, so many women are balancing family, jobs, friends, expectations, holding the aging parents together, and that can really take a toll on women's health. So I think we're looking at what stresses you have in your life, and I guess that covers childhood trauma, secrets that we're holding close to our heart. Those things can manifest as pain as well. So stress has incredible biological manifestations and can really affect our gynecological health. The third thing I probably say, and this is the last thing, is as women, we have a secret power is ovulation. As I said, estrogen is a magical hormone that every single cell in our whole body has receptors for. And if we are able to have a regular ovulatory cycle and our body lets us, that can be to our advantage. And to many women with adenomyosis, we just need to get under control their symptoms, and that may involve shutting off the ovulatory cycle. But if otherwise things are working well, that's a lovely thing to keep in mind with our women's health.
Yeah, amazing. I love that holistic perspective. As you say, you know, we're not just the reproductive organs, we're all of us, all parts of us, endocrine, immune, you know, it's all so interconnected, isn't it? So important to take that bigger picture of our health. And I actually I think I mentioned before we started recording, I did a presentation on stress this morning, and I talk about stress from that mindset of stress, that healthy stress actually has a really important role to play in our lives. But when we're not processing and we're not completing that stress cycle, we get stuck in that tunnel, we get stuck in those emotions, and we feel it in our body, and it does cause havoc with our health, unfortunately.
Yeah, the power of breathing, just something so simple to help bring that adrenaline and cortisol down. Something that we do every day, and it's a little biological hack, just a slow deep inhale and a slow exhale, activate the parasympathetic nervous system, cool that stress down. Things you wouldn't expect a gynecologist to necessarily do is teach you yoga style deep breathing, but it really can be so powerful in terms of actually improving someone's health.
Definitely. Thank you so much for your time tonight, Alice. I really, really, really appreciate it, and sharing your wisdom and tips. So I think there will be so many women who will appreciate that broader perspective and that understanding of the fact that we are all so different, but there are ways to get through these conditions and have a quality of life alongside them. So
yeah, absolutely.
I'm
sure there's something that a gynecologist can help you with.
Definitely. Wonderful. I'll leave it there, and I really do appreciate it. Thank you so much, Alice.
Yeah, you're welcome, Belinda. Okay, bye.